Good afternoon, and welcome to the inaugural IARS Virtual Education Webinar Series. We're pleased today to present Controversies in Care of the Critically Ill COVID-19 Patient. My name is Ronald Pearl, and I have the privilege of both moderating today's webinar and being one of the four speakers. The IARS has a fantastic year of virtual education ahead of us. Registration for the upcoming sessions is now available at IARS.org. If you are a pediatric anesthesia provider, we strongly encourage you to join the Smart Tots webinar on July 13th to hear the latest pediatric anesthetic neurotoxicity research news. Please join us on May 15th and 16th to connect with IARS members in a dynamic virtual education experience for the anesthesiology community. We look forward to welcoming you to our first ever virtual annual meetings, which will offer our fantastic educational content, scientific exchanges, and networking opportunities, all in the virtual realm. We can't wait for you to join us. Registration will open this month. Visit meeting.iars.org for more information. The IARS are proud publishers of Anesthesia and Analgesia and ANA Practice, providing valuable research and practice content to the global anesthesia community since 1922. The IARS COVID-19 Resource Newsletter highlights key articles from dozens of peer-reviewed journals, providing the most useful information for physicians on the front lines of the pandemic. Today's program has not received any commercial support. Following the end of this webinar, you will receive an email with information about how to claim CME credit. If you complete the post-event survey, you will be redirected to the CME website. A recording of this webinar will be available to IARS members at iars.org/IARS-webinar series. During the webinar, you can submit questions via the Q&A button below. Speakers will be available at the end of the webinar to answer your submitted questions. It has now been a full year since the COVID-19 pandemic was recognized as a major problem in the United States and around the world. Globally, the pandemic has affected almost 120 million people and resulted in over 2.5 million deaths. During the three surges, the pandemic has strained not just overall hospital capacity, but particularly ICU capacity. During this year, we have learned an enormous amount about how to care for the critically ill COVID-19 patient. This has markedly decreased mortality. Today's panel is designed to share this information with you while also highlighting areas of continuing controversy. I am pleased to be joined by three true experts in the care of the critically ill COVID-19 patient. Dr. Shahla Siddiqui is an anesthesiologist and intensivist with 18 years of clinical experience in academic medicine. She also has global experience with 8 years of practice in a university-affiliated hospital in Asia. She is a faculty member at Beth Israel Deaconess Medical Center in Boston. Her research interests include sepsis and medical ethics, and she has a passion for medical education. She has published over 80 peer-reviewed articles and received multiple grants. She is an ardent supporter of women's academic and professional movements and is a member of the American Society of Anesthesiologists Critical Care Medicine Ethics Committees and the ASA COVID-19 Council. She has been actively involved in the COVID response and will be speaking on the topic of intubation of the COVID-19 patient, when and how. Dr. Natalia Ivascu is a professor of clinical anesthesiology at Weill Cornell Medicine in New York City. She is chief of critical care anesthesiology and the medical director of the cardiothoracic surgical intensive care unit. Dr. Ivascu is board certified in anesthesiology and critical care medicine and diplomat of the American Board of Echocardiography. She has been involved in responding to the COVID-19 pandemic throughout the past year and will be discussing mechanical ventilation for the COVID patient. Can we protect the lungs? Dr. George Williams is Associate Professor of Anesthesiology and Surgery and Vice Chair for Critical Care Medicine in the Department of Anesthesiology at the University of Texas Health Science Center at Houston McGovern Medical School. He is the medical co-director of the Surgical Intensive Care Unit at Lyndon B. Johnson General Hospital, the medical director of the Donor Specialty Care Unit at Memorial Hermann Hospital, and practices as an anesthesiologist providing care for trauma, complex airway, and surgical patients. He chairs the American Society of Anesthesiologists Committee on Critical Care Medicine and has helped lead the response to COVID-19, including speaking at multiple ASA webinars. He will be speaking today on fluid management in the COVID-19 patient, the kidneys versus the lungs. I will be the last of the four speakers. Again, my name is Ronald Pearl, and I am professor and chair of the Department of Anesthesiology, Perioperative Pain Medicine at Stanford University. I currently serve as president of the Society of Academic Associations of Anesthesiology and Perioperative Medicine and the Association of Academic Anesthesia Chairs, and am president-elect of the California Society of Anesthesiologists. My clinical practice focuses on cardiovascular anesthesia and medical, surgical, and cardiac critical care. I will be speaking on the role of ECMO in the critically ill COVID patient. For today's webinar, each speaker will have 8 minutes for their presentation, and after all 4 presentations, we will have ample time for questions and discussion. Again, please submit your questions for the speakers at any time via the Q&A button in the Zoom taskbar. Thank you, and we will proceed to the presentations.
Hi, good morning. My name is Shahla Siddiqui. I wanted to thank IARS for inviting me for this virtual education webinar. The title of my talk today is Intubation, When and How. I have no relevant financial relationships with commercial interests to disclose, and my presentation does not include discussion of off-label or investigational drugs. The outline of my talk will include a background, conventional parameters for intubation, evidence in COVID-19, controversies, recommended strategies for when to intubate, and precautionary measures for intubation. Now, as we know, with more than 53 million cases of severe acute respiratory syndrome, coronavirus 2, infection worldwide, and the recent new increase in contagions in many countries, the number of patients hospitalized for coronavirus disease has been exceptionally high. A high proportion of patients require mechanical ventilatory support, and rates of invasive mechanical ventilation among patients admitted to ICUs range from 29% in one Chinese study to about 90% in a US study, and from 2.3% of patients admitted to the hospital to 33%. The conventional parameters for intubation include clinical decision-making, which always has varied even with non-COVID ARDS patients. In the LungSafe study, for example, despite everyone meeting inclusion criteria for acute respiratory distress syndrome, 15% of patients were receiving non-invasive ventilation on the first 2 days after enrollment in the cohort. In another study, Mehta and colleagues looking at patients who had what they termed strong evidence conditions for receiving non-invasive ventilation, the authors found huge variability in use of this modality across California hospitals, ranging from 18.6% of patients in the lowest quartile of hospitals up to 42% in the highest quartile, with similar variability in receipt of invasive mechanical ventilation. We have never been able to agree on triggers for ventilatory support, even with diseases that are much better known and understood than COVID-19. Within COVID-19, there has been a pendulum that is swinging from one end to the other of the spectrum. Remember, it's a disease that's only been around for a little more than 1 year, so the evidence is jam-packed within that time period, and it's been published. However, it's across the board, and it's from different parts of the world during different surges in different conditions. The early part of the surge included experience with early intubation in COVID-19 patients. The premise was that if you delay intubation in these patients, the lung suffers more damage, and then finally, when these patients are intubated, their outcomes are worse. However, as we learn more about this disease, the risks versus benefits of early intubations were less clear. And therefore, now we do suggest a trial of non-invasive strategies of oxygenation in an attempt to avoid intubation. And they say that this may not be harmful. However, the large studies are still in process. We'll talk about the controversies about when to intubate. The decision to place a patient with COVID-19 on a ventilator is not clear-cut, and neither are the outcomes. For example, in this graph, we see that if these are patients with early intubation, which is in blue, versus late intubation, which is in orange, you can see that the mean compliance is higher. However, this gap reduces towards the end in 72 hours. Similarly, the plateau pressure the gap is larger in the early period, but then this gap reduces after 72 hours. In this graph by Wunsch et al., we see that the mortality from COVID-19 varies with age, and the gap reduces as the age is higher. So if the patient is older or more frail, whether you intubate them early or later, there is not much difference, and the probable benefit of invasive mechanical ventilation is reduced. The recommended strategies for when to intubate include suggested criteria for tracheal intubation in COVID-19 patients and those related acute respiratory insufficiency, undergoing oxygen therapy, or non-invasive ventilatory support. Prompt tracheal intubation should be performed in the presence of one of the following conditions: alteration of consciousness, risk of airway inhalation, severe decompensated acidosis with a pH less than 7.2, severe hypoxemia, which is known as PaO2 less than 50 or saturation less than 90% despite maximal non-invasive support. In these cases, we should consider tracheal intubation for a saturation between 90 and 92%. Signs or symptoms of significant respiratory distress or tissue hypoxia, example respiratory rate above 25 to 30 per minute, sweating, dyspnea, tachycardia, decreased blood lactate levels, etc., or a decision to implant a VA ECMO. The following criteria probably do not justify by themselves tracheal intubation, and these include low PF ratio, prevention of clinical worsening, severity of chest CT findings, or a logistical, organizational, or medical legal consideration. Now we move on to precautionary measures for intubation. So when we do decide to intubate, how should we do this? Now this graph tells you patients who are within the waiting period where there is a closed individual room provided to these patients, and there's monitoring ongoing, which is very closely done. Monitoring can identify early failure and proceed to elective orotracheal intubation. Compliance with isolation recommendations is very important in such patients, and it is recommended to do the intubation within a room with negative pressure, with PPE available for staff, or if there is a planned aerosol generating procedure, there should be a separate room with negative pressure and PPE. Other recommendations from the Surviving Sepsis campaign include when we do decide to intubate such patients, we should do it with an expert in airway intubations to do the procedure, do it with full PPE, which includes an N95 or equivalent and other infection control precautions. We should minimize staff in the room, and we should consider using a video laryngoscope. If the patient is tolerating oxygen, then we should monitor them closely and target a saturation of more than 92% and do it with appropriate infection control measures. We should not delay intubation if the condition is worsening, of course. And then we should move to this algorithm once that condition worsens. In conclusion, the variability of findings has always existed in studies of mechanical ventilation for critically ill patients. COVID-19 is not an exception, merely an amplifier of these differences. And as one author said, ultimately, if I leave an awake and cooperative COVID-19 patient in the ward with a CPAP mask with a maximum FiO2 allowed, a compensated blood gas analysis with a PaO2 above 50 or 60, despite whatever the PF ratio is, normal lactate levels, and an acceptable respiratory rate, it should be because this is probably the best choice at the moment and not because there is no ICU bed availability. With this talk, I thank IARS and I'm open to any questions. Thank you.
Good evening. My name is Natalia Ivascu, and I'm coming to you from Weill Cornell Medicine in New York City. My presentation today will be on mechanical ventilation. Can we protect the lungs? I have no disclosures. The first and most important thing to know about COVID-19 ARDS is that it is a disease entity that we already do know something about, because COVID-19 ARDS is ARDS. Quite a bit of discussion has been had in the literature about variable levels of compliance, but these variations have also been present in previously studied populations. So while this is a COVID-19 panel, most of what I mentioned can be extrapolated to any patient with respiratory failure. The pathophysiology of ARDS is complicated, but let me briefly review some key elements. In ARDS, there's usually an injury that can be attributed to setting things in motion. This injury leads to macrophage activation and the release of toxic mediators and an inflammatory cascade. As a result of this inflammatory state, there is a breach in the alveolar membrane and protein-rich fluid floods into the alveolar space. The vascular endothelium is similarly activated and results in microvascular injury. This particular portion of ARDS is made worse with mechanical stretch. This can be induced either by the patient or the ventilator and is the focus of what we'll discuss in the next few minutes. Mechanical ventilation in respiratory failure poses an additional risk for injury, although it may be necessary. At high volumes and pressure, the lung becomes overdistended and volume trauma ensues. And at very low levels of tidal volume, atelectasis takes over and derecruitment may occur, which further limits pulmonary function. Over 20 years ago, a major key to lung protection was identified by the ARDSNet trial group. In this well-known study, low tidal volume ventilation was associated with a 22% reduction in mortality. The low tidal volume group was almost 20% more likely to be breathing independently at 28 days, but there was an even bigger reason for the mortality benefit beyond ventilator liberation. The low tidal volume group had on average 2 days less of circulatory failure, coagulation failure, and renal failure than the group with higher tidal volumes. This pivotal study informed our treatment of ARDS, helped us understand ARDS as a total body disease, and also solidified the mantra of 6 milliliters per kilogram. ARDS is associated with regions of normal aeration, poor aeration, and no aeration. The portion of each of these territories determines the overall compliance of the respiratory system. This is often described as the baby lung, in that the functional lung tissue is quite small, like that of a small child. So when we think of compliance, we need to change our mindset from the concept of stiff lungs to small lungs. These small lungs need a small volume, which brings us back to the concept of lung protective settings. First, we want to get as much of that poorly aerated lung working again and avoid losing ground with these low tidal volumes to atelectasis. So adequate PEEP is important to maintain recruitment. Our attention may become focused on the high peak inspiratory pressures, partly because it's the number we see with every breath. Here we have to step back and remember, all pressures are measured at the ventilator, not at the lung. So this pressure may or may not be actually what the lung is exposed to. That number tells us how hard the ventilator is working, or what my colleague calls the risk to the ventilator. Well, we can put that number to the side for a moment and focus on the plateau pressure. The plateau pressure is the pressure that is measured at inspiratory hold maneuver, and that's the best estimate for the pressure seen at the alveolar level and is the real risk to the lung. In the original low tidal volume ventilation study, not all patients in the low group were kept at 6 cc's per kilo, but they did maintain a plateau pressure less than 30. As I said, to determine this number, you have to go to the bedside and perform the inspiratory hold maneuver to know what that number is. So patients with, say, a highly infectious disease like COVID-19 that require extensive personal protective gear, well, suddenly that becomes a little harder to accomplish routinely. We've seen that COVID-19 plus obesity is a particularly lethal combination. There are many potential reasons, but one point is relevant here. The plateau pressure is influenced by the compliance of the entire respiratory system, and this can be greatly reduced by body habitus. In fact, severe morbid obesity was an exclusion criteria in the original low tidal volume ventilation study. The airway pressures in these patients may not accurately reflect the alveolar distension, and traditional protective ventilation may actually result in severely underventilating the patient. It's possible that in these cases, some liberalization of tidal volume and plateau pressure may avoid severe metabolic derangements without actually increasing the risk to the lung. Finally, keep in mind that stretch on the lung is stretch whether it's from the machine or from the patient. In this diagram, we can see the different airway pressures between a patient on controlled ventilation, spontaneously breathing, or partially assisted. In the first column, the controlled breath, we see the airway pressure rise with the air flow increasing. The pleural pressure, which is estimated by the esophageal pressure, is gently increasing during inspiration and decreasing during exhalation. In the spontaneously breathing patient, the airway pressure is negative and the pleural pressure is also substantially negative. And the partially assisted patient receives some positive airway pressure as well as a negative inspiratory force. The transpulmonary pressure is the difference between the airway pressure and the esophageal pressure. You can see that in these three patients, the transpleural pressure is actually the same. This estimates the stretch on the lung. It also emphasizes the point that in the center spontaneously breathing patient, huge negative inspiratory forces and potentially large tidal volumes, although the patient may be generating themselves, are going to apply the same type of mechanical stretch as a mechanical ventilator breath. And this is a real dilemma for patients that are oxygenating okay on supplemental oxygen. But we may need to consider whether these patients making large negative inspiratory efforts, even off the ventilator, are posing an additional risk to the lung recovery, and maybe moving toward mechanical ventilation in those patients, or deeply sedating the awake patient who's on the ventilator to avoid this stress injury may actually be protective. In the last few minutes, I'm going to offer quick practical tips to help make low tidal volume ventilation a success. First is a reminder that the calculation of tidal volume is based on a predicted body weight. Simply put, a patient gets heavier. As the patient gets heavier, their lungs don't get bigger. So the best method to determine the predicted body weight is based on height, as seen in the equation here. All subsequent therapy can be based on this calculation, so the height must be actually measured. In these two examples, you can see the difference of just a few inches in height guesstimation that can lead to big differences in the prescribed tidal volume. And that difference is even more significant in the shorter patient. Low volumes are often require high respiratory rates to meet metabolic demands. And if we don't account for the compression volume of the circuit, we run the risk of shuttling dead space back and forth in the ventilator circuit and barely delivering any gas to the alveoli. The ventilator takes this into account when the ventilation is initiated. So it's important that any additional components in the ventilatory circuit, like the heat and moisture exchanger, extension, or elbow connector, are all attached as shown here before the test is performed. Otherwise, you may mislead the ventilator regarding the compression volume of the circuit and may not deliver the volumes you intend. If I can give you one piece of advice, it's this: you can't fix the patient all at once. Surviving in the long term requires surviving in the short term. So first, normalize the patient. 6 cc's per kilo is the goal, but you may not be able to start there. If the plateau pressure is under 30, the minute ventilation can be adjusted to meet the metabolic demands. 6 cc's per kilo appears to be best, but remember, we don't know for sure if that was a direct correlation or if the patients that had less severe disease were able to tolerate a lower tidal volume. Next, stabilize the patient. Post-intubation, these patients are often vasodilated, and small tidal volumes with rapid escalation of PEEP may worsen their hemodynamics and shock. After the patient has been stabilized, now is the time to slowly reduce tidal volumes and increase PEEP levels to inch toward recovery. So in conclusion, don't forget these three key components: low tidal volume, plateau pressure below 30, and consider whether or not you need to take over to prevent further injury. Thank you.
Hello, I'm George Williams, and I really am honored to have the opportunity to share with you today about fluid management, the kidneys versus the lungs. My disclosure is that I am a compensated educational speaker for Merck-related activities, particularly with the American Society of Anesthesiologists. Our objectives are to recall the underlying physiology of fluid management and then distinguish the renal impact on patient morbidities on patients with COVID-19 and patients with COVID-19 ARDS, and then adapt fluid management principles to patients with COVID-19 ARDS. When we look at lung physiology, we have static versus dynamic compliance. And for the purpose of our discussion, we're going to stick to static compliance because that's what's usable in the intensive care unit environment. And this is clearly related to volume versus driving pressure. The lung already has interstitial capacity of about 500 mLs. But once you get beyond 500 mLs of interstitial fluid added to the lung, that's when you start talking about changes in compliance and appreciable pulmonary edema. And we have to keep in mind also the anesthesia effect. All these patients with COVID-19 are heavily sedated when they have ARDS and they're made prone. And so, for example, this diagram from Nunn's respiratory physiology clearly demonstrates the effects, for example, of FRC, when we actually have anesthesia, when we have muscle relaxed patients, deeply sedated patients. The mechanisms aren't fully known, but we clearly understand that because of the fact that the patient is no longer able to participate in the respiratory cycle, you have increased resistance, reductions in FRC, very, very important changes that are noted that are now tied from our management in the OR, which is now analogous to what we see in the ICU for COVID-19 patients. And then there's cardiac considerations. For example, 20 to 25% of patients with ARDS at baseline have symptomatology consistent with cor pulmonale and right heart dysfunction. This is related to either microvascular angiopathy or also the positive pressure ventilation associated with the fact they're on the ventilator. So we have to be very, very mindful of the cardiac function as well in these patients. And when we look at COVID-19, we have the L versus the H phenotype. And L and H refers to elastance, low elastance versus high elastance. Early in the disease process, there's low elastance, which is a patient that is normal compliance, early stages of the disease. You'll start seeing the ground glass changes on the chest x-ray because you're looking at that 500 mLs or more of interstitial volume, which is what we talked about a few minutes ago. And this gets activated from the fact that it's inflammatory mediators that increase capillary sequestration or fenestration. And then that is associated with the compliance of greater than 50 mLs centimeters water pressure. The H phenotype is different. Late stages of the disease, low compliance, high driving pressures, high requirements for PEEP, and that compliance is less than 40 mLs per centimeter of water pressure. There is an intermediate range, but that intermediate range is not really within the scope of what we're talking about today, but it is something that is mentioned in literature to separate between the H and L types of phenotypes. Now we can assess this looking at lung ultrasound. 94% of patients with COVID-19 have anterior lung abnormalities. Almost 50% of them have pleural thickening. 40% have B lines that are more than 3 B lines per view. And then posterior lateral alveolar pleural syndrome area or PLAPS section also has abnormal findings in about a quarter of patients. And this is what it actually looks like when you actually do a COVID-19 ultrasound like we did in our patients here in the ICU, seeing those B lines, seeing that pleural thickening very, very commonly seen. Now, there was an international survey of about 1,000 practitioners that was done that looked at how these practitioners, most of them, about more than 90% of them were anesthetists in terms of how they predict fluid responsiveness. Echo is very high up there, but pulse pressure variation, passive leg raise, stroke volume variability, very common. We see that the use of vasopressors is very, very common. Inotrope is relatively rare, but echocardiography, look at that. 54% of patients, practitioners are using echocardiography. So this is very, echo is clearly a big part of what we're looking at. But before we get to that, we need to figure out how we're going to assess fluid status. First of all, when we start talking about protecting the kidneys and fluid status, it's got to be accurate in ARDS. It needs to be readily cheap and very easy to implement. If someone has to go to a 2-day course to figure out how to do it, it's not going to work in this pandemic. It needs to be valid when someone's prone and ideally has less contact with the patient, so you minimize the opportunities for using PPE and exposure. I'm going to add a sixth thing from personally, in addition to what Hassanine actually added here, and that is it needs to be abundantly available. I've been in ICUs that run out of Foley catheters, run out of IV tubing, and so therefore it's very important to make sure you have plenty of whatever you're going to be using. The preload assessment types range from passive leg raising, which we talked about, which passive leg raising adds about 350 to 500 mLs of volume to circulation, which you should see an immediate increase in cardiac output. Can't do it when someone's prone. So the synonymous type of technique to use with that would be a steep Trendelenburg position. That Trendelenburg position can actually provide the same effect. You have many fluid challenges, which give you the risk of overloading the patient, but it is something that's doable and easy as long as you're very, very attentive to the way the patient's doing. We have different respiratory tests, which include, for example, inexpiratory occlusion tests. The problem in COVID-19 is that most of these patients aren't going to tolerate things like inexpiratory occlusion because they'll desat pretty quickly. IVC, SVC assessment is very definitely possible, and arterial monitoring is possible. We're going to talk about that now. If we look at IVC variability, most people do it midline. However, you can't do a midline IVC assessment in a prone patient, but you can do a transabdominal approach. This can be done underneath the right axilla while the patient's prone. For example, this is a prone patient. You see cephalad cotted right there. The liver is right there in the middle, and the IVC is right behind it. And so your IVC variability, in this case, for example, is 8%. We knew that this patient had plenty of volume and therefore was not necessarily needing a fluid bolus at that point. When we look at, for example, arterial line monitoring, we can look at this patient right here, and we can actually calculate our own SVV without a LIDCO or specialized equipment by measuring what happens within the range of inspiration to expiration. So for example, 5 to 10 millimeters of mercury is your normal variation. And there's a formula for this. There's SV max minus SV min. So for example, the SV max min is really your systolic pressure as measured minus your at the high one point and low point. So let's say we have 120 as a high pressure in that same respiratory cycle, and then 100 is a low pressure. Mean is 110. Our SVV is 19%. Very easy to do in our own world there. Now, AKI is very common, 10% of hospital admissions, but more importantly, a quarter of ICU admissions. And about 16% of patients that end up in the ICU will need CRRT. Of course, this is more common in older patients than younger patients, and remdesivir did reduce the rate of needing this. I think it's important to point out that every facility does not have CRRT, so this data may not be applicable in your hospital if you don't have CRRT available. Now, CRT has been looked at in the sepsis world with the Elaine trial, for example, and other trials where they tried early CRT to see if you can clear the inflammatory mediators and therefore have the patient do better in terms of sepsis. Now, this was done within 8 hours of stage 2 renal dysfunction versus within 12 hours of stage 3 renal dysfunction. There was only one trial that showed a benefit, but in multi-center studies, you couldn't repeat it. Also, it's been attempted to use high volume ultrafiltration. High volume is anything more than 25 to 30 mLs per kilogram per hour, but it wasn't shown to be benefit in multiple sepsis trial. The IARS CRT trial even tried a really good 70 mLs per kilogram per hour, still couldn't achieve that. But it's important to keep in mind that there is a cytokine module that can be attached to ECMO circuits and CRT circuits. Hasn't been prospectively studied yet, but the thought is that if you can clear these cytokines, which only have a half-life of a few minutes, then therefore you could actually potentially improve the patient's outcome, but this is still yet to be tested. This diagram shows the full spectrum of injuries that can occur to an ICU patient in terms of renal function, high levels of PEEP, left heart dysfunction, all clearly things we can affect there. Of course, drugs, fluid restriction, hemodynamic instability are opportunities as well. So when we look at the outcomes that have been studied, mortality with AKI in COVID-19 goes up 11.5-fold. Age greater than 6 years or severity of highly severe COVID-19 clearly have their own 3 and 6 odds ratios increase of mortality, but also have dysnatremia. Hypernatremia anytime in admission increase their mortality by 2-fold. Hyponatremia at any time can increase risk of mechanical ventilation, but not mortality. But these dysnatremias are associated with volume status, and most times patients are hypovolemic on admission. So we have to be very careful to make sure we give enough fluid to protect the kidneys, but not overshooting. And of course, the PEEP effect is important as well. So we don't want to give so much PEEP that we're causing a problem. So we're looking at conclusion, we're going to minimize volume and barotrauma carefully. And this minimizing volume barotrauma helps the kidneys and lungs agree, because high volumes in PEEP can hurt the kidneys and also hurt the lungs. We want to carefully correct admission hypovolemia, and this is done by precisely measuring it with using whatever tools you have in your particular hospital and calibrating your overall care to your local resources. With that, I look forward to your questions, and thank you very much for your attention.
Good afternoon. For this final presentation, we will be discussing the use of ECMO for COVID respiratory failure. The COVID pandemic was initially recognized in January 2020. Shortly afterwards, there were 3 reports of case series, and in each of those series, ECMO was used in about 3% of patients. By February 2020, the World Health Organization was recommending that patients with refractory hypoxemia from COVID-19 should be considered for referral to centers capable of providing ECMO. This, in fact, makes sense because ECMO can be used to support organ function, in this case, respiratory function, until the disease process recovers, and can avoid additional organ injury, especially ventilator-associated lung injury. It can be used as a bridge to recovery or a bridge to lung transplantation. However, even though ECMO had been successfully used in many patients with viral respiratory failure, the first 4 series of ECMO patients coming from Wuhan demonstrated mortality approximately double that of patients who did not receive ECMO and were otherwise similar. what we're going to be discussing for this session is what's the current data on the use of ECMO, and I'm going to focus on two large registry studies. The first is from the Stop COVID investigators. This was a multi-center cohort study of over 5,000 patients admitted to 68 hospitals. 190 of these patients received ECMO within 14 days of ICU admission. They were typical of ECMO patients, median age of 49, severe hypoxemia with a PF ratio of 72 prior to ECMO. 50% of these patients were discharged alive at 60 days. 1/3 of them had died at 60 days, and another 17% remained hospitalized. They used the larger database for an emulated trial using complex statistical assessment, but essentially they looked at all patients who met inclusion criteria of a PF ratio of under 100, did not have significant exclusion criteria, and compared those with to those without ECMO, and found that ECMO decreased mortality by 45%. The larger registry study comes from ELSO, the Extracorporeal Life Support Organization. They published their initial results in Lancet last year, but they update the data continually, so the data I'll be presenting is from March 1st, 2021. There were over 5,000 cases of the use of ECMO for COVID-19, and 3/4 of these were begun more than 90 days prior to the report. Average age of 50, significant numbers of patients with obesity, diabetes, asthma, and acute lung injury, 6% with acute heart failure. An average of 3+ days from intubation to the start of ECMO, severe hypoxemia with a PF ratio of 70, a PCO2 of 60. The majority of patients on 100% oxygen, 75% on 90% or more. Ventilated with a PEEP of 14 and a inspiratory pressure of 34. Plateau pressures were not recorded. Many patients received prone positioning, paralysis, and inhaled pulmonary vasodilators. The majority of patients were on vasopressors, most commonly norepinephrine. They looked at factors which predicted poor outcome, and mortality was increased with increasing age, immunocompromised state, chronic respiratory disease, acute kidney injury, cardiac arrest prior to ECMO, and initially being on VA rather than VV ECMO. In terms of outcome, almost half the patients were discharged from the hospital, 22% to home or acute rehabilitation, 14% to an LTAC or another location, 11% to another hospital. Only 5% of patients remained in the ICU after 90 days. However, in-hospital death, 48%, most of those within the first month after initiation of ECMO. There were surprisingly few complications, 8% of CNS complications, although patients were on ECMO for prolonged periods of time. As you can see, relatively few significant complications from the ECMO circuit itself. Based on this experience, ELSO has provided guidelines for the use of ECMO in COVID-19. They're very similar to the guidelines for regular ARDS. If patients have significant hypoxemia, the recommendation of prone positioning, paralysis, high PEEP, and consideration of inhaled pulmonary vasodilators. If hypoxia remains severe or PCO2 is above 80 with acidosis, and there are no significant contraindications to ECMO, to proceed to ECMO. The contraindications fall into two categories: relative contraindications, age 65 or above, obesity, immunocompromised status, advanced heart failure, and the need for high-dose vasopressors and not being a candidate for VA ECMO. Absolute contraindications, further advanced age, fragility, mechanical ventilation for more than 10 days, significant underlying comorbidities, severe multiple organ failure, neurologic injury, uncontrolled bleeding or inability to anticoagulate, and ongoing CPR. Also has recommendations for management of ECMO. Mechanical ventilation should have a plateau pressure not in excess of 25, a PEEP of 10 to 15, driving pressure below 15, less than 50% inspired oxygen concentration, a low respiratory rate, and keeping arterial oxygen saturation above 80 to 85%. There are recommendations for anticoagulation, for the use of surface ultrasound, for early mobilization, potentially with a single double lumen catheter, and ECMO weaning protocols. In up-to-date this year, you will find very, very similar recommendations for the use of ECMO for COVID-19 with very few differences. So in summary, ECMO is well established, I would say, as a treatment for refractory respiratory failure due to COVID-19. VV ECMO decreases complications compared to VA ECMO, and we now have guidelines to help identify COVID-19 patients most likely to benefit from ECMO and how to apply this life-saving therapy. Thank you. So I want to first thank the panel, the speakers for 3 outstanding lectures. We do have time for questions. Please add any questions you have to the Q&A. Let me start off, Dr. Siddiqui. There's a question, because we know that mortality significantly increases with age, is there any age limit we should have on when we no longer consider a patient appropriate for intubation and mechanical ventilation?
I think this question is can be generalized to any ICU patient who comes in for respiratory distress and for intubation, not specific just to COVID. Again, there is no age limit to when we intubate people or not in the ICU. It has to be on a case-to-case basis with various ethical questions that need to be answered and patients' contextual issues to be considered. So for this question, I wouldn't say that there's a certain age at which we do not intubate patients just based on COVID data.
And Dr. Ivascu, you talked about the importance of plateau pressure. There's been lots of discussion about driving pressure being equally or more important. Can you comment on driving pressure either in the patient with ARDS or specifically COVID-induced ARDS?
Sure, and thanks, Aisha. We had your question also mentioned, someone also mentioned a similar question in the chat. Driving pressure has been another area of interest in the last few years in terms of an alternative method for lung protection strategy. It's based on the premise that the driving pressure, which is the plateau pressure minus the PEEP, would give us another, maybe a different way to target protective lung strategy. So instead of picking a tidal volume based on the cc's per kilo, perhaps we should look at the driving pressure or maintain a protective driving pressure and let that tell us the volume. In a sense, try to get to get to the idea of the small lungs and figure out what size volume it really can tolerate. I think the short answer is we don't know. I think it's definitely interesting. There's been some, the Amato study, I think in particular was an interesting one in looking back at 9 randomized control trials and pooling together about 3,500 patients to look at the impact of both plateau pressure and PEEP and how that was impacted, how driving pressure was influencing that. And that was showed a correlation between the increase in driving pressure and the increase in mortality. And that was regardless of the PEEP or the plateau pressure. So what that basically tells us is if we target the compliance of the lungs, it suggests that higher plateau pressures or higher PEEPs may not be always injurious, and lower plateau pressures and lower PEEPs may not always be beneficial. I should say the other way around. High PEEP may not be always beneficial. It really is dependent on how they influence the driving pressure. So I think that's sort of a to be determined answer, but it definitely is suggestive that it could be beneficial to maintain a lower driving pressure.
And when we think about mechanical ventilation for the patient with COVID-induced ARDS, are there any differences in our approach to that patient from the approach we would take for any other patient with ARDS not related to COVID?
I think here in New York, where we saw the early massive surge, are always sort of smile when people say that we know so much more now than we did a year ago, because I don't feel that the management of these patients, in many of these regards, has substantially changed. There seems to be still a spectrum of disease when it comes to ARDS induced by COVID-19 and ARDS induced by other conditions. So I guess my personal feeling is that that there's not any clear indication that there's a reason to substantially treat these patients differently than others.
Thank you. Dr. Siddiqui, there are several questions related to the use of prone position. How effective is it at avoiding intubation? And what do you do in the situation where you're now talking about a patient in prone position on 100% oxygen, maybe inhaled vasodilators, who now requires intubation to be able to do that safely?
Yes, so unfortunately, we don't have a trial for every question that we think about, unfortunately, in COVID, although I'm sure that in a few years there would be. Right now, there's no evidence that says that patients who are so hypoxemic that they would be prone and on 100% should not be intubated earlier. So I would still say that, every patient should be treated with the same kind of parameters. And if they are requiring 100% oxygenation and they're requiring proning, then consideration should be given to intubation before we go down the route of having delay in intubating them. There's no evidence to say that proning and not intubating them is better than not proning them and then intubating them earlier. So again, the trials are yet to be conducted or are being conducted. We should take each patient. This disease is very heterogeneous. It's very important not to be dogmatic about either intubating early all our COVID patients or not intubating them and using high flow or proning. So we should take each patient as they come and then see their status and decide about intubating and try not to do things which may lead us down the road of doing something unsafe for the patient.
We are having some technical problems with Dr. Williams. Hopefully we'll get him back on the panel in a few minutes for questions related to his presentation. There were some questions on ECMO to allow patients to be mobilized. In general, ECMO is being used for two reasons, either to actually have the patient recover and not need other therapy, or to allow them to be transplant patients. In both settings, maintaining physical strength and mobilization is critically important. We don't consider patients as transplant candidates if they've been immobilized for a long period of time, and clearly we want them to maintain overall strength and not have severe frailty. So when we put patients on VV ECMO, we commonly will cannulate them peripherally frequently, but then convert to the single lumen, to the single catheter that has the ability through the right IJ to do all of VV ECMO, usually called an Avalon catheter, so that we are at that point really able to get the patients up, and we have many of these patients walking around on VV ECMO. For the patients who we cannulate simply peripherally, so there's a groin catheter, we use the tilting bed, so at least they're able to get to be able to stand and sometimes be able to walk with that. For anyone, there's a question of how often do you exchange the endotracheal tube in the ICU in patients, I assume, with COVID. At least we have not had any particular need to exchange endotracheal tubes other than problems such as ruptured cuffs, et cetera, same as other ARDS patients. I don't know if other of the panelists have had any particular need to exchange ET tubes.
You know, we did see an increase of that requirement back in the spring, and I think that was variable availability of humidified circuits. We definitely had, a number of patients at that time on anesthesia machines, and there was definitely a lot of desiccation that happens, in the airway, and did lead to either, sometimes very acute occlusions. Fortunately, that has not been such an issue this fall.
Dr. Siddiqui, we know that if you look at the studies of ARDS, those patients who have been on non-invasive ventilation for a significant period of time and then require intubation have markedly increased mortality. In the COVID setting, is there a limit to how long you keep patients on non-invasive ventilation?
No, so that's the $1 million question right now is how long can you do without intubating them? And like I said, in the first surge in the spring, our own experience here at BI was that intubating them earlier had a better outcome on mortality. However, as we got more comfortable with non-invasive, especially high flow nasal oxygenation, but again, like I said, these patients are heterogeneous. They're different phenotypes. Some patients will do fine with high flow nasal oxygen, but again, we have to make sure that we don't overshoot the limit and then reach the limit of lung injury. And some patients will require intubation earlier rather than later. The trials are ongoing, so we don't really know what the evidence is. There is weak evidence to say that these patients should be intubated earlier rather than later.
Yeah, I would just add to that, if you don't mind, that I think this does go back to the self-induced lung injury question. In a lot of these patients, I think we observe them breathing large negative inspiratory forces and perhaps are inducing some lung injury even before the point that they get intubated. So it's not so much a delay in intubation. We definitely don't have enough evidence to say that that there's going to be a potential negative consequence of taking over their airway at that point when they are otherwise meeting adequate oxygenation and ventilation parameters. So I think that's again something that we have to continue to study, but that's a potential mechanism for why that might be occurring.
There is a comment about an attendee who's had 3 cases of subcutaneous emphysema without having had either invasive or non-invasive ventilation. And is that common and why does it occur? I would say we've certainly had those cases, including significant pneumomediastinum. Presumably it's what was talked about, which is you can get excessive lung stretch, a lung injury and breakdown of lung without having needed positive pressure. And the old ARDS studies are actually very similar that what we think of as barotrauma is really not particularly related to airway pressure. It's much more related to the degree of lung injury. Other comments on that?
I agree with you. And sometimes it's been quite dramatic. And it was early on, I think, hard to tell if this was just the volume of patients. I mean, we never had so many patients with ARDS in the hospital at one time. And, especially I'm like you have practiced in the cardiac ICU. So it was, a little bit unusual to have that quantity. I think that definitely gave the sensation that there was this huge increase. But no question, it's an extremely destructive virus. And I think we've definitely seen a large percentage of patients having some spontaneous pneumothoraces.
Mm-hmm. There's a question about helmet CPAP, which to my knowledge is really not available in the United States. Has anyone been able to use it here?
No.
I believe there's a trial ongoing for that in Europe, but it's not available like you said.
Right. It does seem to be better tolerated, although it can be challenging because of the quick changes in pressures that has to sense and create. A question about instituting the ECMO before intubation. We certainly have done that, and the patients never require intubation. It does work in the appropriately selected patients. To a certain extent, you're trading the risk of intubation versus the risk of ECMO, and ECMO is not benign, although over time we have gotten progressively better. There's also a question about how long can ECMO go and its long-term effects. Plenty of patients who have been on ECMO for 3 months and then recovered or gone on to lung transplant. There is really no limitation. VV ECMO is markedly better tolerated than VA ECMO. The degree of anticoagulation and the CNS complications are markedly decreased on VV ECMO. In many places, you continue as long as the patient needs it and end up with a good outcome. An issue with the patients who have the highly compliant lungs and are able to take very large tidal volume breaths on their own, not intubated, or after intubation, again, they have very low plateau and driving pressures. Do you treat these patients any differently from those patients who have the normal poor lung compliance with ARDS?
Not particularly. I think that the biggest concern is, especially in maybe the early acute phase, is if the patient is not deeply sedated and they are having more of a partial assist and they're contributing to large tidal volumes. I think that's where it can be problematic, because it seems like they can do it and the pressures are low, so maybe it's okay. I think we still, have enough evidence that the stretch and the large tidal volumes probably add to the injury and are not advisable, although it can seem somewhat tempting when the pressures are low and they seem to be having this need. Certainly, I know it's been observed widely that COVID-19 patients seem to have a really high metabolic drive and therefore have often needed high levels of sedatives to be able to be compliant with either low tidal volume ventilation or just synchronous with the ventilator. And that's where, I think it's definitely tricky or unclear. I mean, it's definitely a hard situation to know exactly which way to go in those patients, but I would just, again, caution to allowing uncontrolled large tidal volumes, because I think that is injurious.
In patients who you're up to allowing to breathe or start to have spontaneous ventilation, triggering the ventilator, etc. Some patients have really stiff lungs, and in order to avoid excess driving pressure, we want to actually have lower than 6 mil per kilo tidal volumes. Without having an esophageal pressure monitor, how do you decide what tidal volume is acceptable in these patients who have really severe lungs and been intubated for a while?
Well, I mean, we have the predicted body weight, and we can go off of estimations and try to minimize it. I mean, there is an impression that smaller is better. As I mentioned in the talk, the idea of 6 cc's or lower being better is not exactly teased out as a causative relationship. We suspect it to be, or have the impression that being able to tolerate some metabolic disarray and some acidosis that may come along with hypoventilation and low tidal volumes is probably okay, and maybe the better part of valor. But I don't know that there's a clear-cut answer to that.
Dr. Williams, welcome back here. Can you explain how you use ultrasound to affect therapy?
Oh, yes. Thank you so much for that fantastic question, Dr. Pearl. I really use ultrasound specifically. I think the volume analysis part of ultrasound is the most key part, just because we have so much lung pathology that we generally see in critically ill patients. And So that being said, I'll expect to see the B lines pretty frequently, and it's kind of hard to purely use that as a way to determine if the patient has optimal volume or not. So in terms of using, for example, IVC variability, that is extremely useful. And I was able to talk about that in the presentation some, but also you can even use SVC variability. It's something you might have seen discussed in transesophageal echocardiography literature, as well as with disposable echocardiography monitors, where you just put the probe right up here, scan right down to SVC, and look at the width and see the variation if it's more than 25% with inspiration and expiration. That's exceedingly powerful and very easy to do with a standalone system like a Sonosite, or even with some of the more portable systems that we see, such as the Butterflies or Sonosite iVises as well.
Thank you. And for any of the panelists, what is the role of tracheostomy in COVID patients who have been intubated?
I'll take that one. At our institution, in the first surge, we started doing early tracheostomies, and we published that as well. Not myself, but my colleagues. And there were good outcomes because they were able to be liberated from mechanical ventilation. But again, large trials are required, and there's a risk of aerosolization. So those things have to be balanced, and of course, the cost for the patient and for the institution as well.
I would agree with that. I think by the time the patients, I don't think we really pushed for early tracheostomy, but if the patients were not weanable and they were, of manageable settings that maybe brief apnea would be tolerated, I think it is beneficial because we start to get into all the secondary complications of critical illness. Maybe helping the patients to be more comfortable, maybe be lighter on sedation or even mobilized. And I think that by the time that happens, they maybe get to the point where they are less infectious and they have less viral shedding. And so we weren't too worried about the aerosolization, but hopefully it gets into the later part of their disease where they may not be as infectious.
And, Dr. Williams, you talked about hyponatremia. Do you think that's important to correct, or is it basically just a marker of disease severity?
That's a great question. I think it's a marker of disease severity. It really just indicates the volume status on admission. It really, in order to actually correct it, it's such a challenge to truly make sure that if it's nephrogenic, for example, or there's a contribution in that aspect, you're really not gonna be able to fix that. So it really ends up indicating the course that you can expect to be able to communicate to the family if that's appropriate or necessary. And even at baseline, if we put in a ICD-10 of hyponatremia, it increases our critical care acuity because of the fact because of the association with worse outcomes at any point at admission, both in COVID patients as well as non-COVID patients. But I generally don't try to specifically correct it. I'd rather just focus on resuscitation. It ends up being corrected that way.
By the way, we'll finish in about 2 more minutes. There was a question about the use of airway pressure release ventilation, APRV, for weaning. Does anyone have particular favored weaning strategies for these patients?
Well,
Since it's a religious question, so I'll leave that to you, George.
Oh, thanks, Natalia. Oh my goodness. I gotta say, I love APRV. It's a fantastic mode for low compliance for the H phenotype of ARDS, particularly with COVID-19. But the problem is that with COVID-19, the oxygenation is just so poor. You get to that point that normally, I guess, for example, when you use APRV, you have a little bit of an increase in oxygen requirement once you turn it on. Many of us probably noticed that. They're desat a little bit, you go by 10%, 20%. But if you're already in that H phenotype that's later in disease, you don't have that margin to work with anymore. So it becomes very challenging to use APRV. So what we end up doing more, is end up working my way up with increasing the IDE time. So that after a few days, you've kind of slipped up and suddenly made APRV happen subtly instead of like just activating the mode directly. And patients usually tolerate that pretty well. I'd love to see if you all see that too, because that's always a challenge.
Yeah, we sort of don't wean them any differently from regular patients. They are extremely challenging, I find, because maybe it's the CNS involvement. It's almost impossible to sedate these patients and keep them from trying to breathe tremendously. Does anyone have, we've tried 8 different drugs and combinations. It just does not work. Anyone have combinations or tips for doing that?
I would say short acting so that, when the time comes, there are no confounding factors for CNS. Like you said, I've had so many patients that I extubated, but they were just not themselves. So that delirium lasts much longer. And due to the first surge shortage of medications, we were using strange combinations. And now we're moving away from that and trying to avoid opiates and longer acting benzos, etc. So short-acting drugs like propofol, Precedex is always preferred.
Dr. Williams, there's a question on how you decide to use diuretics balancing lungs versus kidneys.
Oh, yes. The use of diuretics is actually normally very intimidating because we're always concerned about the AKI. With the 25% AKI across the board, you don't want to push anyone towards that end. But generally speaking, once you're at the point to where you're actually reasonably considering diuresis, you have high volume status from your ultrasound or your pulse pressure variation or whatever system you're using, a little bit of actually Lasix actually can work very, very well, and it doesn't really push these patients over to AKI very quickly unless you're just overzealous with it. So kind of starting low and working up actually still works very well in this population, at least from my experience. And using a diuretic to a very limited end, you can end up getting, paradoxically, those patients that are not going to go into AKI, they can have a very potent response to your diuretic. I have several patients, I'm not sure if the rest of the panel has as well, several patients that you give them 20 Lasix and they are going strong, more so than I would have expected, considering we're always worried about AKI. So if you're at the point where oxygenation is a problem, your compliance is going down, you're not far along in your disease, or volume status looks like it's higher, diuresis is a very good option, and it can be used, as long as it's used conservatively, it can be used very effectively.
Thank you. There's a question on when do you consider a patient who's had COVID no longer be infectious and not require staying in isolation? I expect each of us has their own hospital infection control policies. What do you all do?
For us, it's 10 days of not having symptoms, so no fever for 10 days.
Yeah, so the question is, in the ICU, you have a patient who's intubated, has respiratory failure, et cetera. Is it simply fever? And for the afebrile, you consider that acceptable?
I would go with symptoms because, not just fever, but worsening lung, infiltrates, etc. But if they've tested positive, they could continue to test positive because of false positive results. And just continuing to test them until they're negative won't really work. So I would go with symptoms.
Yeah, we are fortunate at Stanford in that we have created a test that, COVID or SARS is a single-stranded RNA virus. In order to replicate, it has to produce a complementary strand. And we have a test to see whether that complementary strand still exists or not. And so those patients who are still COVID positive, we use that. But if you can't tell, 20 days is usually what we use for sick patients. If we're able to assess that they are not immunosuppressed in the ICU, those decisions are often very challenging. One last thing for each of the panelists. We've now had COVID here for a year. What is the thing that you think you have changed in your approach to these patients? What single thing have you changed that you believe has been most effective in improving outcome? George.
That's a tough one. I would actually say I still think that delaying the intubation as much as possible has been the one thing that I've been, the more we can pull that off, even just engineering ways to keep feeding patients when they're just keeping them off the vent altogether has still been the best way. We're having real challenges achieving a meaningful reduction in mortality after intubation. And so that preventative measure has been the biggest, most palpable or appreciable thing I've seen.
Natalia.
Yeah, I think we're probably similar. Early on, we did the very first couple of weeks, I would say there was probably much earlier intubations, partly because there was rapid decompensation, which I think then emotionally pushed everyone to, want to intubate them a little bit sooner. This was when we were intubating someone every hour. So that was a little bit of a different circumstance. And I think over time that progressed, and now I think there's been a lot more maintaining patients in the step down unit on even high flow nasal cannula, and I think it's a good outcome.
And Shahla?
For me, I think more than a clinical aspect, it's been the family conversations and communication with when we weren't allowing families to come in, and I think that has become a very important part of my rounds. Especially the FaceTime conversations and updating families. I make sure I have time for that. And I think that has taught myself and my team a lot more about empathy, communication, and just the difficulty people have in understanding how bad the situation can be for families.
And I would certainly agree with that comment. For us, it's probably been, delaying intubation for a significant period of time and using, increased FiO2, inhaled vasodilators, non-invasive ventilation, sometimes to avoid intubation completely, and sometimes for these older patients with lots of comorbidities, it allows enough time to really define that this patient's going to have a very, very bad prognosis, and to work with the family to actually decide that the patient should not be an intubation candidate. I want to thank our speakers. It's been a great session, and thank the attendees. They've stayed even though we're already 12 minutes past the hour. Please remember to complete the post-event survey and get your CME. In addition, you'll receive an email with instructions to claim CME credit. So thank you all for your participation, and I hope this is of value to you as you care for these challenging patients. Thank you.